Alrighty, welcome back to another video on To Be a Nurse. It is I, Dave. Dave is I. Hope you all are well. We're doing another little Vsim, so let's have a look. Alright, I wonder if we can, let's retry all these. Looking at the pre-sim quiz. Question 1. The nurse monitors the patient's response to pain medication, especially opioid medication such as morphine, for adverse effects. Which of the following would reverse the effects of morphine? So, Naloxone is an opioid antagonist, meaning it blocks receptors, opioid receptors. Also known as Narcan in the ED and med shows, police shows, if somebody's OD'd on the opiates, Narcan. Question 2 out of 6. The nurse identifies a decrease in urine output in the post-operative patient and considers which of the following as a potential cause. I don't think it's a fluid volume overload. It could be a decreased cardiac output, right? Because it's not pumping fluid through the body. Hypovolemia is low fluid in the body, and these could be both issues and then urinary retention as well. I mean, that makes sense. I'm going to go with these three. Let's see what happens. Lung crackles. That seems not connected. All right. Very good. What do we got next? 3 out of 6. The nurse is aware that signs and symptoms indicating a post-operative hemorrhage include which of the following? Selecting one answer. Alright, decreased blood pressure, decreased hemoglobin. Indicating post-operative hemorrhage. Yep, decrease in blood pressure because there's less volume to go around in the system, and that would also mean if you're losing blood, hemorrhage, you would have less hemoglobin as well. So that kind of sounds right to me, as opposed to an increase in hemoglobin. Increased heart rate, potentially. You would probably need an increased heart rate to attempt to pump more fluid through the system, blood through the system, but it's not matched up with a decrease in hemoglobin. Increase in blood pressure, no. Decreased hemoglobin. I feel like it's this A here, this one here. Alrighty. Signs and symptoms of hemorrhage post-operatively may include hypotension, low blood pressure, rapid thready pulse, disorientation, restlessness, sweating or urinary retention. Yeah, low urinary output, cold and pale skin. Beautiful. Which of the following statements is true related to post-operative management of pain by the nurse? One answer. True related to post-operative management of pain by nurse. Nurse should assess the effectiveness of pain medication within 30 minutes after administration. That sounds pretty good. A major concern of administering narcotics to a post-operative patient is drug addiction. I don't think it's a major concern. I'd table that for now. Pain medication should be given only if the pain is severe. No, I guess the idea is to we're trying to make the patient feel comfortable, I believe. Intense pain will help the patient by stimulating the stress response. No, I don't think so. I think we want to assess the effectiveness 30 minutes after administering. Very good. Question 5 out of 6. The nurse monitors the patient for which of the following major post-operative complications after an abdominal hysterectomy. So the removal of the... Come on, Dave. Not ovaries and fallopian tube. It's the uterus. Come on, Dave. Get with it. Select all that apply. Major post-operative complications. Could be hemorrhage, could be infection. I'm going to say bladder dysfunction. Deep vein thrombosis. because they're going to be quite sedentary, or sedentary. They'd be very static and stationary. Bowel obstruction. I don't think so. We're not really doing anything in the small or large intestine, but there could be some push on the bladder. All right, let's go with this. All right, look at this. We're on a hot streak. I have done this before. Not very recently, though. It's been a little while. We've just been learning lots. Question 6. Which of the following interventions should a nurse consider to minimize the risk of post-operative deep vein thrombosis, DVT? Shout outs. Select all that apply. Sit up in a chair for as long as tolerated. That's actually going to probably encourage the blood to pool at the legs. So I don't think we want that. We do want them to move around. I'm not sure about the pillows under the knee. I'm not sure about minimizing ankle movement. But the anti-embolic stockings sound like a pretty good idea. I think these two are strong. I'm uncertain about the pillow under the knee. Let's have a look. There you go. Prophylactic treatment of deep vein thrombosis includes the use of the stockings, encouraging early ambulation. It's also important to avoid pressure behind the knees. Of course, it's blocking circulation. Will constrict the vessels, blah, 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 blah. 83%, not bad. Not bad, Dave. Let's launch the sim. Time to launch the sim. I know I've got a bed hair this morning. Bed hair at 120 in the Arvo. That's a problem. I need to get my in order. Let's have a look, Doris. Good to see, good to be. Let us hear it.
The patient is Doris Bowman. She is a 39-year-old female who underwent a total abdominal hysterectomy with bilateral salpingo-oophorectomy under general anesthesia this morning. Mrs. Bowman tolerated the procedure without complications. Estimated blood loss is 400 milliliters, and she received 1 unit of packed red blood cells during the procedure. She was difficult to arouse from anesthesia and has experienced pain postoperatively. Mrs. Bowman was experiencing increasingly painful and heavy periods along with fatigue and was diagnosed with uterine fibroids, dysmenorrhea, and menorrhagia. She recently started iron tablets for iron deficiency anemia. She awakens easily, responding to voice. Current vital signs are temperature 98.4 degrees Fahrenheit, 36.9 degrees Celsius, heart rate 90, respiratory rate 16, blood pressure 130/86, and SpO2 95% on oxygen, 2 liters per nasal cannula.
So looking
Pain
good.
level ranges from 2 to 6 out of 10. Lung sounds are clear. She has a midline abdominal incision covered with a 4x4 dressing with no drainage noted. Bowel sounds are hypoactive.
Cool.
An IV of normal saline is infusing at 90 milliliters per hour. She has a urinary catheter in place with 200 milliliters urine output. She received ondansetron IV for nausea and the scheduled IV NSAID at 0900. Vital signs are now every 15 minutes. You can review her post-op orders and labs in the chart.
Alrighty, let's jump in. Ooh, not so quick. As you prepare to care for your patient, what complications are they most at risk for? Select all that apply. DVT, yes, it was kind of brought up in the previous quiz, so I'm just going to say for sure. Pulmonary embolism. So low blood sugar, I'm not going to say that maybe, but I don't feel like that's... Yeah, I don't think so. There would be monitoring BGLs and... I don't know. I feel like that's not going to happen, the low blood sugar. Pulmonary embolism, I guess if there is bleeding or fluid, leaking in the system or around the thorax, the chest and lungs. That could be a possibility. Pain for sure. Infection for sure. I forget what that is. ATELECTASIS. I think I've got a nursing dictionary here. Let's have a quick look. ATE CDF. Atelectasis. Atelectasis. Failure of part of the lung to expand. Okay. So not a lung collapse, not a neurothorax. Not pneumothorax. Occurs when the cell lining of the alveoli are immature and premature. But so I'm not gonna say that. These three for sure. Pulmonary embolism is kind of in the same realm as DVT. Let's go for it. Let's see what happens. Oh, okay. So was those four? I'm not sure about this explanation. Clients undergoing major surgeries with limited mobility during and after surgical procedure are at high risk for lung collapse. Okay. Early return to mobility and interventions such as turning, coughing, deep breathing, and incentive spirometer are initiated to decrease risk of the atelectasis. All right, cool. Learning. Let's go say hi to, okay. We won't say hi yet. We've been given the SBAR, the handover, so situation, background assessment, and recommendations. Recommendations is vital signs every 15 minutes, so we're just doing some post-op check. Diagnoses, we've got some bloods, HB, hemoglobin, little low. I forget what HTC is. I should really know all of these, but I know a few of them, but only a couple in the reds there. Clinical observations, so very important to know the threshold or parameters for a MET call. So any observations in the purple area, and they're talking about this. This is an observation chart. Respiratory rate here. Last time we did obs was 25 minutes ago. Yeah, so if it lands in this purple area here, so greater or equal than 36, that's a MET call. And then you got your clinical review, senior nurse review, and increased surveillance. So these two are escalation, and this is the MET call, and this is just keeping your eye on there a bit more. So we know from the handover that all the vitals were in normal ranges. They were last given, or Doris was last given on Danzatron for nausea relief at 9, so 40 minutes ago. Ketorolac is a NSAID, so a non-steroid analgesic, whatever it is. NSAIDs. Inflammatory drug. Anyway, pain relief. It's similar to ibuprofen, I believe. So that was given at 9 o'clock, and it's every 6 hours. So we actually can't give that for a while. I imagine within this scenario. So we've got morphine, 2 milligram bolus, which is just a instant all-in-one push through the IV. Naloxone will be the antidote or opioid antagonist if the morphine gives us respiratory depression. We've got an infusion of sodium chloride for fluid replacement, fluid resus, I'm not sure if we'll have to use the strip rate here. Maybe. Radiology, nothing. Orders. Bunch of orders. Push every 6 hours. Push every 2 hours. PRN, so as per required or as per needed. And the respiratory rate has to be greater than 18 to 20. So, interesting. Respiratory rate currently was 16. So, yeah, if she's in pain, I really don't have too many options, do I? Ruh-roh. Administer morphine as ordered if pain score is equal or greater than 6. Naloxone and PRN respiratory rate is less than 8 or change in level of consciousness. So if she becomes confused, dizzy, sedated, that kind of thing. We don't have 12 lead. Alright, let's just jump in here, okay? Female, has a partner Jack, married, black, Baptist, account manager. Good life. Let's get in there. Close and play.
Hi, I'm Amy. I'll be your primary nurse today.
I hurt. Please give me something for the pain.
Alright, I hear that. First we need to do... Alright, so when you jump in, you know, these kind of clinical environments, the first thing we want to do is wash our hands before we do anything. We want to do some patient ID. Identify the patient.
Please state your name and date of birth.
My name is Doris Bowman. I was born on February 10th, 1987.
Yeah. We would also do like a safety check. So we would be checking the oxygen
matches
on the wall and the suction, making sure that they're working. We'd be, you know, checking for clutter around the bed, and would also be checking that the brake on the bed is on. All right, so we've ID'd, hand hygiene. We want to do some consent. Obtain some consent, informed consent.
Hi, I'll explain today's plan for you, and we can discuss any concerns or questions you may have. Is that okay with you?
I have no concerns or questions at this stage. I am happy with the plan.
And the last thing we need to do in terms of, you know, before we get into assessments is ask about allergies.
Are you allergic to anything?
No, I am not allergic to anything.
All right, so heart rate's at 112. That's bumped up from 90 where it was before. So that's kind of indication of a bit of pain happening aside from her telling us that she's in pain. So we need to ask her about her pain. We want to go pain assessment. Describe the pain.
Can you describe the pain?
It hurts around my stomach. Please give me something for the pain.
Yeah, yep, we will. So we need to get a rating from it.
How would you rate your pain on a scale of 0 to 10?
It's pretty bad. I give it a 6.
Give it a 6. So in terms of if we can give her morphine, as I said before, if her respirates under 18, then we can't give it. So we have to respiratory assessments. We have to assess respirations here. So if it's 18 above, we can. Okay.
She is breathing at 21 breaths per minute.
Beautiful.
The chest is moving equally.
All right. I guess we want to just attend to the pain right away. We will connect the blood pressure monitor, just to keep an eye on that.
Blood pressure cuff, so we can monitor your blood pressure continuously.
So she has IV access.
That's fine with me.
IVC access, intravenous cannula. We want to check that for patency and also for signs of phlebitis, you know, inflammation, redness, soreness, swelling, that kind of thing. That's before, whoa, her BP is real high. Okay, that's, Let's pause that for a second. Let's go back to our chart here. 154. So we go clinical obs, blood pressure. Okay, so the systolic, which is the top one, is at 154. So this is on the high end. But if the systolic dropped in the 90s or had a big drop from here to like, 110 or 100, then we'd probably be going for a METS call. Currently, we're all good. Let's look at the heart rate. Would we escalate because of the heart rate? We would at this point, right? We would go number 2 here, which is a senior nurse review. So I think we want to do a review next, right? Med, officer, nurse, escalate. I think we would call medical officer, maybe. All right, let's go IVC or IV access. We'll assess the access.
Let me just assess your IV.
Ashesh.
Okay.
They could do better with the these voiceovers. The patient voiceover is cool, but
The site has no redness, swelling, infiltration, bleeding, or drainage.
all right, beautiful. So
The
let's
dressing is dry and intact.
great. Let's do a flush.
An infusion of 90 milliliters per hour of sodium chloride 0.9% is running.
And then I guess, look, let's just quickly go through the vitals. So we've got heart rate, we've got oxygen levels, we've got blood pressure. Let's just quickly do temperature.
I'm going to take your temperature.
We've got the pain score of 6.
Sure.
Okay, cool. And now we can go into the
temperature is
medications, I think.
98.6 degrees Fahrenheit, 37.0 degrees Celsius.
So we'll stop this. We'll add new drug.
An infusion of sodium chloride 0.9% has stopped.
Morphine IV push in the arm. 2 milligrams. I'm going to flush before and after. Scan medication and verify. Administer. Now, this could be...
2 milligrams of morphine.
This
has
could go
been
bad,
given.
so... Okay, we've given morphine. We're going to keep our eye on her. Her heart rate has dropped. Oh, things have already changed quite a bit. Her heart rate is dropping quite quickly. Let's ask her about her pain. Ask about pain.
Can you describe the pain?
It hurts around my stomach. Please give me something for the pain.
Uh-huh.
How would you rate
Oh,
your pain
she's looking a
on
little-
scale of 0 to 10?
Odd here. That heart rate is dropping. I think...
There is no pain.
Alright, we're going to do a Met call right now. Do Met call. And we also want to... Alright, administer the Naloxone. We want to
Code team
do
will arrive shortly.
respiratory... 3 breaths a minute.
She is breathing at 3 breaths per minute.
Let's go to our
The
drugs.
chest is not moving very well.
Naloxone. Let's go provider's orders to see how much it was. 0.4 IV push. Let's close that. IV arm 0.4 push. We'll flush before and after. Administer. All right. Sorry for picking my nose there. You just caught me. What findings would indicate your patient is improving? I guess blood pressure. Resp rates is the big one. The OSATs have dropped below 90, so I think we can put in a cannula if she didn't have a nasal cannula or nasal prongs. Put 2 liters of oxygen through there. I'd go OSATs and patient alert and oriented. All right, nice. Cool. While blood pressure monitoring is a priority post-operatively, it is not an indication that the client's respiratory status is improving. Beautiful. Return to the patient.
0.4 milligrams of naloxone has been given.
Airways, breathing. So we're going to do A to E. Airways, breathing, circulation. All right, so she's back. How are you? How are you feeling?
How are you feeling?
A little better.
Interventions, respiratory interventions. Actually, where was it? Can we increase this to 4? And let's do maybe a simple oxygen mask. We'll get the SB2 up, I think. All right. What about the pain? Because the naloxone's blocking those, blocking the pain. No, it's kind of opening up those pain receptors. It's blocking the effects of the morphine. So let's ask about the pain.
Do you have any pain?
Yes.
Oh God, that's not good.
How would you rate your pain on a scale of 0 to 10?
It's pretty bad. I'd give it a 5.
Okay. All good. Let's listen to the lungs.
I need to listen to your lung sounds with my stethoscope.
Sure. No problem.
And we need to check respirates as well next. So in the A to E assessment, A is airways. You're just checking to see if there's any obstructions. If people are speaking, if somebody's speaking to you and they don't look like they're in any discomfort, then airways is good. Breathing is respiratory rates. It's auscultating, so listening to lung sounds. Seeing if the trachea is midline, which is normal, or if there's a deviation, so if it's off to the sides. E for effort, which is like, are they using accessory muscles to help with their breathing? Either the shoulders, sometimes diaphragm, so lower near the stomach. And if they can complete full sentences without having to take a breath. So I'm just observing my dog off to the side. A, B, C, circulation. So we're looking at blood pressure, heart rate, capillary refill, pulses. So radial pulse under the thumb on the wrist, pedal pulse on the foot. You follow the webbing between your big toe and the toe next to it, all the way to the top bony part, and that's where you can feel your pedal pulse. And you would do it on both sides as well to check for, I guess, bilateral strength on both sides. Let's listen to these lung sounds. One here, that sounds good. Is it the right upper lobe? Sounds normal, I guess. I don't have a whole lot of experience listening to lung sounds, so... That sounds good, that sounds good. Gonna go normal here. Down here. There's also the back as well, but... It's all sounding pretty good to me. Beautiful. All right, so let's pause for a tick, right? Doris was in a lot of pain. There were 2 medications charted, but one had already been given at 9 o'clock, and you can only give them, and they had to be 6 hour, have to give them 6 hours between the next dose. So we couldn't give that one, which was... We couldn't give the ketorolac, the NSAIDs. So we were only allowed to give morphine, and that was Hmm. Morphine when required. Where was that other info? Pain level, lung sounds clear, midline. Yep. Orders. That's what we want. So the ketorolac, push every 6 hours. Morphine, 2 hours if the patient's respiratory rate is above 18, right? So we had to check that first before giving them morphine. We also, if the pain score was greater than 6, we could give morphine. So because the morphine knocked Doris out, we checked the respiratory rates. It was 3. Another intervention we could have done earlier is just like adjusting the face oxygen mask and putting the oxygen up to 4 or 6. Probably could have done that as well. Yeah, we probably could have done more with that particular assessment, but she's back now, so that's great. And then we gave the naloxone push because the respiratory rate was less than 8. It was actually 3, which is real bad. And we did notify medical officer. We can repeat in 2 to 3 minutes if no response, but she did respond to it. So we've done full vitals because we got the heart rate, blood pressure, oxygen saturations. We did the respiratory rates. We checked the temperature, so we've done a full set of vitals. We haven't done a full A to E assessment, but up top we did ask for allergies. We ID'd, we got the consent. We washed our hands. We checked for IV access as well. So at this point, we're going to take the oxygen face mask off. And we'll keep the prongs in, I think. And then essentially, I think we want to do a handover. And we want to essentially get the medication reviewed, the morphine. Have another option for pain. All right, let's jump back in. We'll go play. I'm going to go oxygen here. I think we want to go nasal cannula. We want to drop it down to 2. Apply. Heart rate is high. Let's ask about the pain now. Again.
Do you need something for the pain?
Her heart rate's pretty high, so yes.
Please.
All right, so essentially, test and diagnostics. No safety measures. Hand hygiene. Oh, cool. I could have just done it all in that. I didn't know that was there. Interventions, respiratory, post-operative. Nice. Call for assistance. Med team, medical officer. Probably call medical officer, yeah?
I'm going to call your medical officer.
Because we want to talk about the
Sure, go ahead.
what we can do about the pain and the drugs. The drugs. Explain
I
the
have explained
situation.
the situation, background, assessment, and recommendation to the medical officer.
Yeah,
The medical officer is coming to see the patient. We will
beautiful.
continue with existing orders.
I don't think we have any more orders, right? Oxygen maintained. Greater than 92, which is good. Indwelling catheter tomorrow. Intake and output every 4 hours for urine. Gone through the meds. Got the ECG on. I think we're ready for the handover. Let's go to the SBAR. Alrighty, select all that happened. So she developed respiratory depression. Checking vital signs every 15 minutes would go under recommendation. History would go under background. Pain and needed analgesia. The situation is like what is important right now, what needs to be conveyed right now, the top priority. So, very important information. She developed respiratory depression. Select all that applied to background. Okay, yep. Oriented 4 times, maybe not. No emergical or surgical complications. I think these two, right? She underwent a total hysterectomy. removal of uterus, and has no medical or surgical complaints. I think these are good. We'll see. Select all that apply to assessment. Maybe that naloxone was administered. This is a recommendation. This is maybe situation. But that would be I for like identify in SBAR instead of SBAR. I think that I think naloxone was administered. It could be none of these, but recommendation. Medical officer needs to be contacted to discuss alternatives to a pain medication. I think I did that, but I should still put that in there. We want to continue to monitor respiratory rate for rebound respiratory depression. Yep. SpO2 target should be greater than 92. She's on nasal prongs, but we'll keep it that. We don't need the last blood pressure. That would have been under assessments. Let's have a look at the performance. Let's break it down. Let me know how you think I went or what you think. Oh, 68%. See, it seemed like we went well, but not so well. Perhaps. Let's have a look. You should have provided positive pressure ventilation when the patient was not breathing adequately. So when Doris passed out, we should have put the face mask on right away, right? The breathing mask. Should auscultate the abdomen, so listen to the abdomen to assess bowel sounds. True. We kind of didn't get there, right? We wanted to address the pain right away. Yeah. That's a tough one. Like, I get it. You should probably just go through your A to E before you give the pain medication. It takes 5-10 minutes to do the A to E. I guess they can wait. Should have assessed the patient's dressing. Yeah, okay. So post-surgery. Should probably write some notes. Post-surge. Wound site. Yep. And then I double activated the Met team. Bad. Alright, what are we looking at here? Alright. Let's have a look. Automatic non-invasive blood pressure. Nice. Reviewed. So around at this point. Yeah, at this point I was she was in pain. So I stopped my assessment. Because, for example, if the pain is associated with a complication with the surgical site, that should be noted and addressed and dealt with. Some kind of intervention. But I didn't complete a thorough assessment, so my bad, Doris. My bad. Okay, so the patient's respiration rate dropped below 6 breaths. I should have provided positive pressure ventilation when the patient was not breathing adequately. Yeah. Big naughty here. Positive pressure ventilation. Write that in your notes. Positive pressure ventilation. Double activated the Met team. Recess breathing. 3 flush can. Naloxone. Should auscultate the abdomen. I mean, come on. I'm in the middle of saving her life. You want me to check her? I mean, you want me to listen to bowel sounds in the middle of that? It's wild. All right. That's not bad. It feels like 68. I mean, that's nothing. I agree with that. Yeah. I suppose I agree with that too. It was deserved. Small errors can be big errors. 81% with the handover. Yeah, okay, that was unnecessary information. Unnecessary information. Because, I mean, that's essentially saying nothing, right? That's a sentence that just says, oh, nothing's wrong. But this gives a big indication or clue as to the situation. That is not an assessment. Yeah, I was a little bit iffy on that, but the recommendations were good, and this is best practice. Keep that on the screen for a sec. Thanks for dropping in, watching the sim. Please subscribe if you feel like this is quality content, and if you want a little more, you want to hang around, you want to stick with me. This was fun. I feel like we smashed this out in pretty good time, even though this video is probably going to be 40-50 minutes. Yeah, enjoy. Stay well. All right, bye.